I'm also delighted to introduce Cristina Polito, a scientist at the World Health Organization, or WHO, and Human Reproduction Program, where she leads on harmful practices, including FGM as well as child marriage. Her work focuses on the development, testing, and integration of evidence-based approaches that strengthen health systems and promote gender equality and rights. She has more than 2 decades of experience in research and programming on gender-based violence, harmful practices, and reproductive health. And lastly, I am delighted also to welcome Helen Sankany, Clinical Support Officer at the End FGM Model Health Facility in Narok County. With 10 years plus experience, she focuses on maternal and reproductive health, GBV and FGM prevention response, and community health education in rural areas. She has supported the ACCAF, I will put these acronyms in the chat, don't worry, a pioneering integration model in advancing FGM abandonment and training health professionals in survivor-centered care. So before we get to the panel discussion, we really wanted to show a video that kind of sets out the model health facility in action, and shows you just how innovative it is in the area. So I'll pass over to Mark, who can show the video now. Oh, the video's not playing. Perfect.
Audio Jungle.
The implementation of the model health facility in Narok County brought out several lessons. One of them is that it is true, the FGM is prevalent in most of the countries, including Kenya, and in most of the ethnic groups that we have among them, even the Maasai. And therefore, this is a challenge that community is living with. It opens us up an opportunity for us to have a candid discussion between the health system and the system that exists with the community about the practice.
Once we train our final year students, we collaborate with the ACAF, who normally place our students in the Regengare Modern Health Facility, which integrates end female genital mutilation interventions into clinical services.
I got involved with them in a training healthcare workers on prevention and response to FGM. And it's really been wonderful working with them. And now I am the staff supporting them to work with this facility in collaboration with the Narok County government to integrate FGM prevention and working with communities to prevent FGM, and also to work with survivors and the community at large.
Part of kazi yenye sisi tunafanya hapa pia ni kulinda wasichana wetu. Na kitu ya kwanza tunasema watoto wasichana wote wapelekwe shule na wasome. Si mtoto akisoma anajua kujisimamia na kujisemea kitu anataka. Mtoto atajua kujitafutia pesa zake. Na mtoto atajua kujitafutia maisha yake baadaye. Kitu ya pili tunaongelea kuhusu watoto wasichana, tunasema watoto wasichana wasitahirishwe. I had an understanding about FGM, what I learned in books and school and trainings, workshops, but now coming and handling people who are survivors, it creates a form of empathy. Interacting with FGM survivors in this facility has helped me understand better about how I integrate my healthcare skills in dealing with patients, and that is holistic care, that it's involving their spiritual health, mental health, and physical health.
So I've learned that I'm not just a healthcare provider. I'm not here to just treat them. You have to meet them at the physical level, emotional level, mentally, because you see sometimes others they are afraid of talking about their state. So it has taught me that it's not just treating them. You have to meet them physically, emotionally, and mentally.
I'm from the Maasai society, where FGM is still being practiced. From my society, the male figure are mostly the decision makers. And given that I'm a medical personnel now against FGM, I will use my position to be able to mobilize the society and also act as a resource personnel towards educating the public on the disadvantages of FGM.
Welcome to Narok Encourage Sub-County Hospital. So here we are in a model skills lab that students like us are meant to come and learn various skills about FGM, how you're supposed to manage them, and just to remind ourselves about what we learned in theory back then.
The practical skills that I've learned through Skills Lab at the Model Health Facility in Narok Sub-County Hospital is that we have the dummies there that we can use to learn about handling post-FGM or FGM survivors, and especially for learning how to do delivery for an FGM patient, how to conduct an episiotomy to an FGM patient, and how to handle some emergencies that come with complications of FGM, that is like hemorrhage and trauma.
In the facility, I came to the facility and they sat down with healthcare workers and healthcare promoters. They were able to develop tools that are used in different service delivery points, like in antenatal, in family planning, in outpatient, and we are able to collect data on FGM in all the service delivery points. I think this will really be the first data to be collected, which is more detailed and can really be used by the government or also by ACA.
The model health facility being the model health facility in the entire country and also in the region, that is the African continent. We hope to see learnings across the region, because emanating from what the county has said, they're positioning it as the one of its own kind model health facility. All our healthcare workers within model health facilities have undergone training to ensure the support works around FGM prevention and response.
The model health facility came to Narok County as a blessing to us. One, it has increased the health-seeking behavior in the community. If you go to the Gengari facility, you check the numbers that were there before the health model facility came in, and now it tells you the impact because the numbers have increased. The county has improved the services. They're upgrading the level 3 to a level 4, which means we'll have services like theater services that were not there before. And this is coming due to the need, which was identified by the coming in of the model health facility. Initially, in the Kenya Health Information System, you could not get data for FGM, but currently you can go there and just get the data.
Looking at the impact of this model health facility moving forward, I see a situation where this is going to be a sustainable model of delivering care to women who have complications arising from FGM. But even more importantly, I see this model health facility being a catalyst for abandonment of FGM. So in the next 15 years, you are going possibly to have only women who have had FGM coming with complications with the FGM, but very few girls who have been exposed to FGM because FGM will end.
Brilliant. Thank you so much for sharing that. I believe we also have a video from the WHO, a quick video that will showcase their work in this space. If I can ask the TGG to put that on the screen. Thank you.
This is Leah. She's a midwife. Every day she helps deliver babies and cares for women. She also supports girls and women living with female genital mutilation. Leah knows that the practice of female genital mutilation has to stop. It's a dark cloud that hovers over the community and the future of all daughters. But how to change a practice that seems so deep-rooted? It's true. Leah is just one person, but even one single drop of water can set off a ripple that reaches the other side of the river. As a midwife, Leah touches the lives of so many people. She's a caregiver, a teacher, a communicator, and a trusted advisor. With each person she meets, Leah has a chance to start a conversation about female genital mutilation and encourage change. In each role and with each conversation, she can plant a new seed of hope. Hope for a future without female genital mutilation. And working together, midwives and other health workers can help end female genital mutilation.
Brilliant. Thank you so much for sharing those. I hope for those who are kind of maybe coming to this topic a little bit newer, those two videos give a real overview of just the importance of integrating FGM prevention and care into the health system and services that are provided. And the UK has a real interest in this. We fund partially the Narok model health facility in Kenya, and are really interested in seeing it as a model be kind of repeated elsewhere globally. Fantastic. So the next stage of this session will focus on a panel discussion. So I already introduced you to our three fantastic panelists earlier. So I'll welcome them onto the screen, and please pop your cameras on. And we're going to go through a series of questions. Then we'll open it up to questions from all of you as well. So don't worry, there will be time for questions from the audience shortly. But to kick things off, I wanted to ask all three panelists to introduce yourselves and what you do in this space. I'll start with Professor Kimani, if possible.
Thank you, Rochelle, and good evening, good afternoon, members. I am Professor Samuel Kimani. I work for the University of Nairobi and a center called ACAF. And in ACAF, we conduct research and train healthcare workers to be able to respond to FGM through prevention and care. Specifically, we train healthcare workers who are medical doctors, students undertaking midwifery and nursing. And in my work, we found it fit to make sure that the next generation of healthcare workers are skillful, knowledgeable, and empowered to undertake prevention and response to FGM. And this undertaking was informed by work done by the WHO, of course, the training manuals and the books that have been developed by WHO. From that work, we were able to build the evidence from 2025 moving up to 2029 under the funding of the UK government, where we actually found that despite that healthcare workers are supposed to have the knowledge and the skills to address FGM through prevention and response, there was lack of integration. So the services were a bit scattered, and we couldn't get any referrals, and there were challenges, especially responding to psychosocial and mental health arising from FGM. And even more scaring is actually the emerging issue of medicalization. And medicalization here, we talk about FGM performed by the healthcare workers. So as ACAF, we under the UK government funding, one of the components that came out that we need to push is integration. And integration here means that we no longer address FGM as a standalone. We need to integrate it into ongoing programs, including health, nutrition, immunization, so that it can be sustainable and the community can see a lot of relevance in that. And how did we move on? We move on because one of the issues we understood is that the content that is taught in the universities and colleges was actually not enough. So as ACAF, one of the things that we undertook is to develop a curriculum that can be used to train medical doctors, nurses, and midwives. And then we went ahead to train the lecturers who are in the universities and colleges, and the lecturers would go ahead and train the students. So, but as we continued training them, we understood that there was also a gap, especially in what we call the skills. So we needed a space or even facility where a student can go and they can be able to offer care, but in the process they can hone their skills and they can also offer a care to the women and girls. And that is how the model health facility was born. So in the process of implementing the model health facility, we realized that there was lack of data, there was lack of resources to train healthcare workers, and there was an emerging group of healthcare providers whom we call the community health promoters, who work in the community where FGM happens. And therefore, through adaptive programming, which is a core pillar of a TGG-ALM program, we were able to develop a curriculum that can be able to build capacity and knowledge for community health promoters. And this curriculum is basically a layman's curriculum, which can actually be replicated to train religious leaders. It can be replicated to train community leaders and even other people who are not medically trained. So with the ACAF and the TGG-ALM integration model, our approach has been what we call a whole system approach. And the whole system approach approaches from the national perspective, where we work with the curriculum and policies, and then we target the service delivery points. And here we target healthcare workers who are already working in health facilities, but we are also now down working in the community through the community health promoters building their capacity so that they can be able to reach women and girls in their households, but also girls and boys in schools, but also the hard to reach women and girls through outreach services, integrating End FGM intervention into immunization, into nutrition, into women and security and peace and security and all these interventions. So one of the beauty thing about the program that we're implementing is the potential for sustainability, because people will never stop going to the health facility. So when we anchor End FGM intervention in the health facility, we are actually saying even the future generations are going to be reached through this intervention. And that is the sustainability we are talking about. And even more importantly is the potential for scalability. Our model is simple enough, and we have tested this in Kenya, in Senegal, in Somaliland, and Ethiopia, and it has been the results that have been posted demonstrate that this is a model that can be implemented with simplicity. So I want to stop there in case there is any question. I can be able to speak as we move on. But generally, that is how the model looks like. Of course, working with other stakeholders like WHO and the Ministry of Health and the county government, it has been possible for us to deliver what we have delivered through what you call trusted relationship. And the trusted relationship do deliver results. Thank you very much.
Thank you. That was really, really useful. And we'll come back to scalability later on, because I'm very keen to kind of hear more about kind of ideas on that. Next, to introduce herself and explain a little bit of what she does in this space, I'll pass to Christina. Come on in.
Hi, thanks so much, Roisha, and welcome to everybody. Thanks for the organizers for this event. So basically, I'll first introduce myself. So I'm Christina Polito. I'm working at World Health Organization in Geneva, also working at HRP, which is a research program on sexual reproductive health and rights co-sponsored by WHO and other UN agencies. So basically, WHO uses a public health approach to address female genital mutilation. And what I mean by that is like we do with all health issues, we know that there are a lot of people who are already affected by different health problems, including FGM. And in the case of FGM, these increase health risks, whether these are risks to physical health or mental health or sexual health. It's important to make sure that those who've been affected receive the care and treatment and respect and respectful care that they deserve. And on the other hand, we work on the prevention side. So what we've really done, and I'll come back to this in a moment, is working on developing materials to build the role of health workers as advocates against FGM. And we do this work, this public health kind of approach in three different ways. And one of them is on developing guidance and standard setting evidence-based materials. And these can be guidelines where we take existing evidence and we develop recommendations both for the health sector and beyond. So it can provide kind of a blueprint of action for Ministries of Health or Ministries of Social Affairs and other partners to implement at the country level. So that's an important aspect of the work we do. We also have a global strategy against the medicalization of FGM that also can serve as a kind of, again, as a blueprint of action for countries to take in ending medicalization in particular. And then on this work on person-centered communication, you saw a bit in the video. This is kind of an innovative way of working with health workers, and we recognize that midwives and nurses provide the majority of care and most of the first-level primary care in most countries where FGM is practiced. So they've really been a target group, and recognizing that important opinion leaders, that they're respected in their communities, that they operate at this intersection between the health system and the communities where they work. And they can play this important role, but they need the skills and they need the experience and the resources to be able to do this. So we've been working with them to do sort of values clarification work and to do work around learning person-centered communication and role-playing and how they can kind of bring this within the context of providing routine care for those that they serve. The other way that we work is in generating and compiling evidence, and this can feed into the evidence-based recommendations that we develop. This is around also on the epidemiology of the practice, health risks, health economic costs as well, and then also testing what works. So this person-centered communication approach that I mentioned in this training, we have tested this in 3 countries, in Guinea, in Kenya, and in Somalia, and found really, really promising results. We've shown that health workers learn these skills, they actually had these communications, and those who sought care from them actually were less likely to have intentions of performing FGM on their daughters. And then the third way that we work is in supporting countries. So making sure that these resources are then integrated at the country level, that we're strengthening health systems as we integrate them. Building skills of health workers is a key component of that, and similar to the work that Professor Kamani has mentioned. And then just making sure that we have a multi-sectoral approach as well. So the health system is a part of a larger effort at the country level, and these national plans that exist can include a strong health component, and there's a lot of amazing work happening at the grassroots level. Other systems are also involved, but bringing the health system into this is really critical, and it has been a missing link for, I think, some time, but we're really trying to close that gap and strengthen this work. Thanks, I'll stop there.
Brilliant, thank you so much. And again, we're going to go into what works later on, because everything you said was really, really interesting, and definitely keen to dig into that. The final panelist is Helen. We'd love to welcome Helen in to kind of set out a little bit about what she does more at the kind of country level.
Thank you so much, Roshi. And my name is Helen Sankaine. I'm a nurse midwife with some years of experience serving women and girls in rural communities. I am serving currently as supporting ACAF as a clinical support officer to help integrate FGM prevention and response into the services provided in a model health facility, which is in Narok County. It is called Nairagi and Kare Model Health Facility. And this facility is a facility providing care to communities where FGM prevalence is high. And what makes the model really unique is that FGM prevention and response is an integral part of all the care provided at each service delivery point. And what makes it unique is that it creates an enabling environment for healthcare providers to discuss FGM with survivors and other community members in a sensitive way that is culturally sensitive. And this has only been made possible through the training that the healthcare providers receive. what we do is receive, after the students have attained the training from the training institutions, they are able to be placed at the facility where they are able to come hands-on and interact with survivors and also sharpen their skills on providing quality care that is really sensitive to the clients who are coming to seek services at their facility. So we receive students from different institutions, from universities and mid-level colleges in Kenya, and they're able to rotate in the facility and sharpen their skills before translating the knowledge they had in schools into the real world experience in the community. And we are also able to go to the community and schools to offer same messaging around ending FGM.
Brilliant. Thank you, Helen. That's brilliant and really, really useful. And thanks to all panelists for introducing themselves and just setting out a little bit more of the context of specifically their role in this sector. We will now move on really quickly to questions. I am going to ask a couple of questions myself, and then I will open it up to the floor. So please do, if you've got a burning question, think about it and we'll come to you very shortly. But the first question I have is for Helen. So you've done it a little bit in that opening kind of segment, but if you could just share a little bit more from your perspective on the ground at the Model Health Facility, what it looks like in practice, what sort of health-seeking behaviours are you seeing?
Thank you so much. So the Model Health Facility is just a health facility that provides the routine care that all facilities provide. But now the model makes it unique because it is able to create an environment that clients and women feel safe, not only to discuss FGM, but also to seek services that are really critical to them. And the facility is unique in a way that all the staff are trained, that they are able to offer services and also including referral and treatment to the complications that come with FGM. And the seeking behaviors that we've seen with the facility being introduced at this health facility is that the numbers have really gone higher, and the facility has been receiving more clients coming to seek services, which has really we have seen it as a change over time, and this has really increased the number of even the number going higher. If the hospital is able to get even more support from other institutions, like they're able to claim more funds from the Social Health Authority, from the government. And this has enabled the facility to run better, not only financially, but also to acquire, to even employ, for example, a sonographer who would offer simple obstetric ultrasound that women previously would seek elsewhere. An example is previously at the facility, before the model was inaugurated, we would barely reach a minimum of attending we would previously reach a monthly target. But in the past 2 years with the model, the numbers have really gone higher. Like in the month of August, we've seen 170% achievement of the targets of women seeking services. This will not only translate that the trust and the value that the community is putting on the services, but also provides the chance for women to seek quality care at the facility.
Brilliant. Thank you so much for that, Helen. That's really useful. Okay, now on to the next kind of question. I was going to ask all of you, but perhaps I kind of pass to Professor Kimani to kind of start us off on what works and what doesn't to integrate FGM into the health sector. So yeah, what are your kind of learnings from your experience on the kind of key things that colleagues on this call will need to get right and to ensure that integration is effective, and what should they look to avoid in trying to integrate FGM care and prevention in health systems and services? So Professor Kimani first.
Thank you, Roche. What works? One of the learnings that we have picked through our implementation is that integration needs to happen at multiple levels. And for us here, integrating at where the source, and here we are talking about the source here is where are we getting the healthcare workers in the training institution? And I say this, we must develop tools that can support the capacity building. So a whole system approach would really work. And this must also go hand in hand with partnership and collaboration. As a program, we could not have succeeded if we didn't have the support of the county government and the Ministry of Health. But even more importantly, as we continue to implement, we actually brought in more stakeholders on board. And I'm happy even in this meeting, we have people from Desta University, we have people from Egerton University who originally were not part of the plan. But as we continued implementing, they have now started to place their student in the facility. So this means that this is a success story which can actually build a whole synergy of institutions to try and address a typical problem like FGM. The second thing is evidence-based decision making, very important. And this is one of the pillars, as I said, that is very well anchored in the TGG-ALM. So as we implemented, there are a lot of things we didn't know before we started implementing. But as we continue implementing, a lot of learnings came in, and these learnings informed how we continue to implement. And I think moving forward, this is a really important thing, that if you are a programmer, you must be flexible enough that every time you implement, get the evidence and get the feedback, and then continue implementing so that you don't waste resources and you become more efficient. The third one that is even more important is in doing integration, we must be innovative and we must demonstrate what is new. I think in our training, one of the things that have really motivated the healthcare workers and the students to undertake FGM prevention and response is that there is value add to what we have done. One of the things is within our training, we anchor it on the human right approach, where we say zero tolerance to all forms of FGM. And within this, we really emphasize on making sure that there is no healthcare worker who is qualified to perform FGM. And in our training, one of the things is actually we even compare and we ask who among the cutters, either a traditional cutter or a doctor, who is more qualified. A doctor would be a quack in performing FGM. And that is the innovation we bring. And we find the healthcare workers actually even being shocked to hear that medicalization is a crime. And then added to that, there is a procedure by WHO, and I'm happy to report that one of the procedures we train our healthcare workers is defibrillation. Defibrillation is a gold standard. When we have a woman who have undergone the severe form of FGM, the type 3 FGM, when you want to help her live a quality life, to give birth normally, to improve the maternal and child outcome, healthcare workers must learn defibrillation. In our situation, if you ask all the healthcare workers who are practicing, most of them perform other procedures, but our value add here has been demonstrating and taking them through the skills of performing defibrillation. So for me, I think, and of course, the final bit is technical support and mentorship. We must be ready FGM is very sensitive. It is very technical survey. We must be ready to support, especially the primary health level healthcare workers, so that they can continue to hone these skills and they can continue providing quality services. And of course, finally, co-creation and co-designing. This is one of the most tremendous outcome that we found with our collaborators, that when you develop resources and tools together, then they become more acceptable, then they are contextualized, and they are more likely to be usable, and that can promote sustainability. And finally, when you are training, we train through building local capacities. Building of local capacity is important because then it can afford you the opportunity to co-train, and during the co-training, then you also mentor each other. And even when you pull out of the program, maybe because of lack of funds, you are assured that the training will continue and capacity building will continue. I'll stop there. Thank you very much.
That's really helpful. Thank you so much for that kind of overarching view, just really reinforcing that it's at every level that this integration is needed. The capacity building is absolutely critical to kind of long-term success, and really anchoring it in a human rights-based approach, like fundamental to this working. So no, thank you very much. I'll pass next to Christina for the same question. Christina, is there anything maybe not already said that you think actually is absolutely critical to what works in this approach?
Yeah, thanks, Rorsha. This is, I'll build on what Professor Kimani already mentioned. In terms of the building the capacity of the health workers, I think there's a lot of questions about how that's done. And, also it's meeting the health workers where they are. So if you kind of think of it as a spectrum of, at one extreme, you might have health workers who strongly support FGM, who are performing FGM, medicalized FGM. And on the other end of the extreme, you have those who are advocates against it. So the way that you have to approach this is you have to make sure doing this work around values clarification and really trying to unpack the beliefs of the health workers during the trainings, because you're trying to train someone who is performing FGM that's very different than someone else who maybe is, I don't support FGM, but I don't quite know what to do about it. So it really is important to have this step where you do values clarification, where you unpack around traditions and beliefs and rights, not necessarily using the language of rights, which may not resonate sometimes in these sorts of trainings, but really trying to understand, the well-being of women and girls and making sure that they don't experience any harm. So that's a really critical component of that. And then also this what we've incorporated in the training is to teach person-centered communication. And we have tested this and we do have evidence. We had control groups and exposed groups of health workers. And it really is teaching steps of how you do communication that's in a way that's not just telling somebody what to do, but that's having a conversation, interaction, and keeping the woman at the center of that conversation, really understanding where she is when she is trying to make her decision about whether she should have FGM performed on her daughter. So this really person-centered approach is really critical. And then, these entry points, I think, is a really important aspect. We've used antenatal care because it's a natural entry point for reaching women. And if they're pregnant, they may be pregnant with a daughter, they might have a daughter at home or a niece. So this is a really effective entry point. The immunization entry point, we're also doing some research looking into that about potential area of reaching other members of extended family in addition to mothers who are pregnant. And I agree with what Professor Komani has said on these other points, but just also to add that we know that we need a multi-sectoral approach. We know this, right? But what we know is that it's not like we need grassroots action, and there's all sorts of work that's happening that's really important and impactful, but we also need that systems level approach. So it's not one or the other. We actually need both. We need systems that are strong, that can prevent and respond. We need them to be coordinated, and we need them to work closely with the work that's happening at a grassroots level. So, rather than dichotomizing, is it this or this, we need both, and we need to be coordinated, and we need to integrate. But I can come to that in the next question and give time for Helen to respond as well. Thanks.
Thank you so much. Helen, it would be brilliant for you to come in now and kind of set out what, from your perspective, what works, but also what doesn't work. What have you seen that you think, actually, please stop doing this? This hasn't helped with the integration. Over to you.
Okay. Thank you so much, Roshi. Yeah, as my colleagues have said, the integration is working, and as having FGM and prevention and response as part of the services offered make it seamless and also enable the clients to receive holistic care, that is physical care, emotional care, and psychological care. But handling FGM as a standalone would definitely fuel more stigma and create more barriers in addressing. FGM being a culturally sensitive issue, it needs a lot of sensitivity and respect. And if, for instance, a client walks in for an antenatal clinic and you go directly and ask her about FGM, she can easily get offended. This will be bridging the rule of do no harm or do safeguarding. But after you given attention to her needs sensitively and attended to her needs comprehensively, this will create a very enabling environment, not only for her to discuss her own perspective, but gives a chance for you to discuss why we should protect the girl that she could be pregnant of. So that's what I think is working, and that is what we have seen at the facility. We have worked with women, talked to them during antenatal clinics, family planning, and even when they're coming for immunization. And when you talk to them, they are not aware of they're just aware that FGM is illegal and it is not allowed, but there is minimal knowledge on the health consequences of FGM. But when you take time to discuss with them after creating that good rapport, they're able to listen and even change their mind on safeguarding the girls that they are carrying, and also speak up in the community as our ambassadors.
That's so helpful. And yeah, absolutely. It feels like this is deeply rooted in the ability to connect with survivors and kind of those using the health facility, making sure that you have that kind of authentic relationship or connection so that you can then build trust and go from there. That seems fundamental to success in this area. The final question I have before I then open up to everyone else is, in your mind, how can we scale this? This is such a great kind of innovation, the model health facility. What needs to be done to kind of scale this, and so that we can kind of use it in different contexts and settings? I'm conscious of time, so if I can ask everyone to give very quick, short remarks in the answer, and then we can open up to the rest of the group. But first, I'll maybe go back to Helen first to kind of talk about the scalability, and then we'll go back down the line. So we'll go to Christina, and then we'll go to Professor Kimani.
Thank you so much again. Sustainability can only be achieved by anchoring these approaches to the already existing structures like healthcare and education, because we know that healthcare, people will keep seeking for services, children will still go to school. But if we anchor it, when we anchor FGM prevention into these services, it will really be sustainable. Also empowering local governments, from the national government to the county governments, will allow and make it enable them to enact policies and strategies that can trickle down to the grassroots and remain even after governments change and even after political positions change.
Brilliant, thank you. Christina, do you want to come in?
Yes. So reaching the next generation of health workers is critical to make this sustainable. So making sure that we reach those before they have their licenses is important to, then we have another generation of health workers, as well as reaching those who are already in practice. But in terms of sustainability, that's really key. The integration, we talk about integration in a lot of different ways, integrating it, the topic into, not verticalizing the topic and integrating it into other sexual reproductive health topics. We have incorporated FGM prevention and care elements into the universal health coverage compendium that countries use to develop their universal health coverage packages. So that's an important element as well. We're trying scaling up in also in Guinea at the moment, and also bringing this to immunization services and trying to saturate different regions of the country. So we have some learnings around that as well. And, bringing in different partners and ensuring that we have coordination. And then finally, I would just say that evidence and generating evidence and making sure that we learn from work that's happening, incorporating different evaluation components and into the programming is important, so that we know what's working, so we can learn from that, so we can better direct our resources to improve, to scale up, and to develop evidence-based recommendations that we can then bring again into guidelines and other materials that inform action of health system strengthening approaches in different countries. So I think there is a lot of learning out there already, and I think we need to reach other countries with this approach. We're really happy that Kenya is using it, and that the products that we've developed have influenced the model health facility, and we're always looking for opportunities to collaborate with other partners to scale this up. Thanks.
Thank you very much, Christina. And finally, Professor Kimani, what's your take on how to scale this up, the successes that you think are possible here?
Thank you. I'll be brief. I think one of the challenges in the health sector is actually competing priorities, and we have a lot of problems that need resources and government attention. So we need to see how FGM find itself in the table of the people who allocate resources and do policy direction. And FGM need to be a priority, and that is very important. The second thing, of course, is capacity building tools. Developing capacity building tools is not enough. You need to go a step further and make sure that you actualize by training the healthcare workers. And what does that mean? We have developed so many capacity building resources. One of the things is to make sure that we disseminate this to the different actors so that they can pick them for utility in the different geographies, especially for example, the Community Health Promoter Training Manual, the Ministry of Health Training Manual, so that the training can actually start to happen and we can continue to sustain and scale up this process. And finally, of course, making sure that we anchor the issue. Like one of the things that we have done in Narok is to make sure that we have anchored End FGM intervention in the work plan for the county government. So if we can be able to lobby for those interventions to be anchored in the government financial system, then we know that resources can be dedicated towards supporting those interventions, and therefore that can promote sustainability and scaling. Thank you.
Brilliant. Thank you so much to all our speakers today. It's just been fantastic to have your kind of wealth of expertise with us to kind of share your perspectives on this critical issue. I will now stop asking the questions and let you guys ask the questions. I know that we've had 2 questions already kind of submitted. If there's anyone else with an interest in asking a question, do pop your hand up. I think we have a question from Alice in the chat about whether it's only Narok or other hospitals in Kenya, and whether this kind of model health facility is elsewhere. I think, Professor, you mentioned this model has been mirrored elsewhere, but I just wanted to come back and ask if you could kind of clarify where such a facility kind of exists at the moment, and then I can bring in Vic to ask the next question.
Okay, so if I can jump in, this model is the first one in Kenya and possibly in Africa, but I'm aware that in Mauritania we already have a small model that is also being developed. The one that we have in Narok, we have some partners who have expressed interest to develop one in Kajiado. So, and I would encourage the stakeholders who are here. It is not expensive to develop such a model. So don't be worried. If we are here to support you, and the main issue is to make sure that you train the healthcare workers, especially using the PCC and the modules that we have provided. Thank you.
Brilliant. And I'm not sure I'm seeing any hands, but we have a question from Vic, one of my colleagues, who asks about the rollback or the pushback that we've experienced maybe on this model health facility. Have we experienced pushback from local government, religious leaders, or anyone else, any other community groups on this work? If so, how have we managed to mitigate this? And then a second follow-up question is just how can the UK government continue to support work like this? How would you like to see the UK government continue to support the work you're doing? I will stop and pass to Professor Kimani first, and then let the other panelists come in if they have inputs as well.
Okay, thank you. We haven't experienced any pushback because our approach was very intentional. We did a lot of stakeholder engagement so that we address any emerging issues. In fact, one of the worries, I mean, and when you read the literature, people say if you start asking people about women about sensitive issues about their FGM status, most likely they may stop coming to a facility. That was one at the background of what we were doing. But apparently, we have not seen that. In fact, as Helen said, we have seen an increase in the uptake of the services against all the odds. And number two, this facility has actually created demand. In fact, if you walk around Narok, people are saying we have FGM. Can we have even reconstructive surgeries to repair the injuries that were caused by FGM? Of course, that is something that we are thinking that we can be able to offer moving forward with the collaboration of the stakeholders. So we have not seen any pushback, and we have seen a lot of support from the county government and also the national government, and we are looking forward for even more support. Yeah,
that's brilliant. Helen, Christina, anything else to add?
Yeah, just to add on this issue of pushback, because I think it's really an important issue, and it is definitely something that we see in a lot of different settings. In particular, we saw what was happening in the Gambia last year, where there was a push to try to overturn the law there, and there was a lot of work done with partners, and they were bringing in religious leaders from other countries, from Egypt, and also health workers to try to have those conversations and try to influence those sorts of decisions and dialogues at that level. There is a demand for accurate and trusted information as well, so I think that's absolutely critical. The guidelines and the materials that we produce, Ministries of Health tend to see these as trusted sources. The public sees them as trusted sources. So it's really important that we maintain that. But we see a lot of pushback on this issue and a lot of other issues. And yeah, I think there was another part of the question too. Yeah, I mean, the way that the UK can support this, I think it's really just ensuring that we're doing coordinated and evidence-based programming across sectors. And I think that's the key here. I mean, and using rights-based approaches and making sure that information on health risks, which is evidence-based as well, to make sure that these human rights arguments, how this violates the rights and well-being of girls and women in so many ways is really critical in these discussions too. So that sort of advocacy, as well as conversations that happen at a national level, at a global level, and that happen at a community level as well, I think are all important, that they remain evidence-based. Thanks. Over.
Helen, finally, is there anything you would like to add?
On the pushback, just to add on what Professor Kimani has said, we have not seen much since because of integration, that the clients are able first to get what needs brought them to the facility comprehensively and sensitively. And then this will enable them to really build a good relationship and a good rapport. And I think from the video we have seen, like the ground is ready, as the pictorials in the walls can talk to the clients. And by the time you meet them, they're already aware that, yes, FGM can be discussed in this facility. So that's really enabled the environment to be very simple and easy to talk about FGM. But after you have offered the services that they came to seek at the facility, and even the communities are like eager to get services, because with the students coming to rotate and the turnout time becomes shorter, and now they feel that the services the services are quality, and they are coming more and more. So this has really made it seamless and quality care to deliver to the clients.
Brilliant. Thank you so much to our speakers again. Your time is very, very valuable, and we're really grateful that you gave us an hour today. I can't do your brilliant words justice by summarizing it, but I think the kind of three things I've taken away from this is, one, we need to be thinking about this integration at all levels, at kind of kind of global state government, kind of country government, and at the local level, we need to be integrating FGM prevention and care throughout our health services. So I was really struck by the comments on kind of women and girls coming for immunization treatments and being kind of encouraged to consider kind of FGM support and care through that avenue. I think that's really, really key. Think about it in a kind of holistic manner. And then lastly, just do not underestimate the importance of evidence. We need more evidence. We need to be making sure that it's really robust, and we need to be using that to kind of influence and encourage leaders, be that at all levels, to really properly and strategically integrate this kind of care into health systems and services. I will stop there. Thank you so much again. We're going to put a slide up now that has a list of resources that you can access that touches on the model healthcare facility that we spoke to today. So I'm hoping the Girl Generation group will be able to put that slide up now, or maybe we can weave that even, share that with attendees at a later stage. And then lastly, we did have a little questionnaire that we were going to ask attendees to kind of fill out just on what you learned from today. So we'll pop that on the screen as well if we can. And if you have the time to kind of fill out your responses, that would be amazing. It's very quick. It's only 2 questions. But just a huge thank you again, and thank you very much to Helen, to Christina, and to Professor Kimani, and also to Options, who kind of put this all together as well. I'm really, really grateful, especially in 16 days of activism against gender-based violence, where this is a very, very busy period for everyone working in the gender-based violence space. But this was an absolutely critical conversation to have today. So I'm really, really grateful. I will stop there and let you all get on with the rest of your day. But thank you again to all our speakers and to you participants. Bye.
Bye.
Bye. Thank you.